Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Randomized Trial Using the GnRH Agonist Triptorelin for the Preservation of Ovarian Function During Adjuvant or Neoadjuvant Chemotherapy for Breast Cancer by Pamela N. Munster and colleagues. My name is Ann Partridge, and I am a medical oncologist at the Dana-Farber Cancer Institute in Boston, Massachusetts. My oncologic specialty is breast cancer, with a particular focus on unique issues to young women. This podcast discusses the findings from the manuscript by Munster et al. Regarding the use of ovarian suppression for fertility preservation in young women receiving adjuvant chemotherapy in the context of the current literature and future directions. Fertility and premature menopause are major concerns for young women with breast cancer. Young women with breast cancer face particular challenges when considering future fertility after cancer compared with other young cancer survivors. First, there are concerns that pregnancy in a breast cancer survivor could increase the risk of recurrence, particularly in patients with hormone receptor-positive disease. While there have been a number of observational studies that have suggested there is no detriment from having a pregnancy after breast cancer, concerns remain for many women and their providers. And even if a woman does not go on to become pregnant, fertility preservation, using continued menstrual cycling as a surrogate, has been associated in observational data with decreased survival in women with hormone-sensitive disease. Whether suppressing ovaries in women who remain premenopausal after chemotherapy reduces risk in the era of tamoxifen is the subject of ongoing study, notably the suppression of ovarian function with triptorelin, or a SOFT trial, which has now closed to accrual. Second, for women who are interested in a future biologic child, breast cancer chemotherapy can diminish a woman's fertility even if she does not go through immediate menopause, making pregnancy more difficult to achieve. Third, standard hormonal therapy with tamoxifen for women with hormone-sensitive disease entails 5 years of treatment during which a pregnancy is contraindicated and a woman's ovaries are aging and thus fertility is declining. Finally, it can be difficult to tell whether a breast cancer survivor is fertile. A woman who is menstruating may be infertile, and women who are amenorrheic, especially on tamoxifen, which can affect menstrual cycling, may remain fertile. For women who are interested in a biologic child after breast cancer, as well as those who are concerned about the potential effects of premature menopause on quality of life, sexual functioning, bone, and cardiovascular health, there has been great interest in trying to maintain menstrual functioning after breast cancer chemotherapy. Reported rates of chemotherapy-related amenorrhea and premature menopause range from 10% to 90%, depending on age, treatment regimen, and length and method of follow-up. Several uncontrolled studies have suggested decreased incidence of amenorrhea with the use of gonadotrophin-releasing hormone, or GnRH agonists, through chemotherapy compared to historical controls. The use of these agents is appealing, given that they are readily available and are generally less cumbersome than available alternative strategies, including undergoing in vitro fertilization and embryo cryopreservation prior to treatment. However, available data have been mixed from both human and animal studies, and reproductive biologists have questioned the biologic plausibility of GnRH agonists preserving fertility and argue that randomized controlled trials are needed to evaluate efficacy. Munster and colleagues present one such trial in the JCO. In their study, premenopausal women ages 44 and younger were randomized to receive triptorelin or no triptorelin during adjuvant or neoadjuvant modern breast cancer chemotherapy. In comparison to prior studies, Women were stratified by age, ER status, hormonal therapy use, and chemotherapy regimen. The main outcome measures were resumption of menses and FSH and inhibin A and B levels. The study was stopped early for futility after 49 patients had been enrolled of a planned 124. Menses resumed in 90% of the women in the control group and 88% of women in the triptorelin group with a p-value of 0.36. There were also no difference in the time to return of menses between the two groups. The median was 5.8 months in the triptorelin group and median 5.0 months in the control group, p-value 0.58. 2 patients were reported to have had spontaneous pregnancies in follow-up, both of whom were in the control group. The measurement of markers of ovarian reserve, including FSH and inhibin A and B, measured at baseline and serially in follow-up, appeared to show diminished fertility in both groups over time and were consistent with the menopausal status of the patients in general. This study provides important information for our evolving understanding of the potential role of ovarian suppression in women with breast cancer. They used rigorous definitions of continued or resumption of menses, and there was follow-up of a median of 18 months. Importantly, they accounted for age mix, chemotherapy regimen, as well as the use of tamoxifen in their analysis. Tamoxifen does not appear to have an effect on fertility per se, though it clearly can have an effect on menstrual functioning in premenopausal women, and this can impair the ability to use ongoing menses as a surrogate for ovarian function and fertility. This study is one of 6 recently completed or ongoing randomized trials designed to address this important question. The findings are consistent with the smaller Zorro trial, Zoladex Rescue of Ovarian Function, which, as was recently published in this journal by Gerber and colleagues, revealed no difference in return of menses among 60 women randomized with hormone receptor negative breast cancer to goserelin or not through modern adjuvant chemotherapy. Preliminary data presented at the 2010 ASCO annual meeting from the OPTION, or Ovarian Protection Trial in Estrogen Negative trial by Leonard and colleagues, also suggests no clear benefit with regard to resumption of menses for women treated with ovarian suppression, in this case goserelin through adjuvant chemotherapy in short-term follow-up. Importantly, in both of these studies, biomarker surrogates of ovarian reserve and fertility, such as FSH and inhibin, were collected and provide important data for future research, although the lack of timing with menstrual cycling and follow-up is problematic, given that most vary within the menstrual cycle. In contrast, Del Mastro and co-investigators recently published findings in JAMA from a much larger Italian trial of 281 women randomized to receive triptorelin or not through adjuvant chemotherapy, which revealed a higher rate of treatment-related menopause, defined as no resumption of menses at 1 year after completion of chemotherapy, and postmenopausal or unknown E2 and FSH levels in the control group, 25.9%, compared to the triptorelin group, 8.9%, with a 17% absolute difference with a 95% confidence interval ranging from 26% to minus 7.9%, p-value less than 0.001. Badawi and colleagues have also published in Fertility and Sterility in 2009 findings from an Egyptian study in which 89.6% of premenopausal women with breast cancer resumed menses and 69.2% resumed spontaneous ovulation within 3 to 8 months of termination of a GnRH agonist and chemotherapy co-treatment, compared with 33.3% who resumed menses and 25.6% resumed normal ovarian activity in a control group who received only chemotherapy without GnRH agonist treatment. The POEMS, or Prevention of Early Menopause Study, SWOG 0230, a large international multi-center trial led by the U.S. Southwest Oncology Group, randomizes women with hormone receptor negative early breast cancer to receive goserelin or not through standard adjuvant chemotherapy. The POEMS trial continues to accrue and will undoubtedly provide additional important complementary information regarding biomarkers of ovarian reserve in follow-up, as well as rates of long-term amenorrhea and premature menopause with or without ovarian suppression through treatment. At this time, in light of the most recent results from this well-conducted study by Munster and colleagues, and the conflicting results In particular, from Del Mastro et al., the role of ovarian suppression through chemotherapy remains uncertain for prevention of premature menopause, and especially unclear for fertility preservation, given the lack of data from any study that actual fertility outcomes are improved with GnRH treatment through chemotherapy. Women who are interested in future fertility and their providers who are assisting them in these oftentimes difficult decisions should consider this strategy experimental for now. We await mature results from ongoing studies to determine whether this technique actually helps to maintain surrogate markers of fertility and prevent premature menopause in young survivors through chemotherapy. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.